Hello, everyone. Welcome to Ask Concussion Doc. My guest today is Dr. Shirley Blanc. Hi, Shirley.
Hi.
Dr. Shirley Blanc is a neuro-optometrist in downtown Toronto. She is a fellow and advisory board member of NORA. For those who don't know, that is the Neuro-Optometric Rehabilitation Association. She's also a medical advisory board member and contributor to our concussion training rehab program with Complete Concussion Management. She's also an external referral source and research collaborator with the University of Toronto's David L. McIntosh Sports Medicine Clinic. Her clinical practice focuses on the assessment and treatment of patients with visual dysfunction from concussions of all types and severities, and her patients range from athletes, both professional and amateur, to members of the general public with vision-related issues due to concussion. So Shirley, welcome to Ask Concussion Doc. How are you?
Thanks so much, Kim. I'm good. I'm good, thank you.
Do you have snow where you are today?
Not yet,
No?
but apparently it's...
We woke up with a little dusting, so it's on the way. Winter is coming.
It is. It is for sure.
So let's kind of start off light here. Let's talk about just neuro-optometry in general, and what is a neuro-optometrist versus, kind of a regular optometrist. What's the differentiator? How is that different?
So, a general optometrist will check, how clear vision can get. So with the optimal prescription, whether it's glasses, contact lenses, laser surgery, consultations, ocular health checks. They'll do, in a general exam, we check for gross sort of eye movement restrictions, gross or sort of large binocular vision issues, peripheral vision testing, glaucoma screening, all these things. But when someone comes in with a concussion, a general eye exam isn't necessarily enough to know why they're experiencing what they're experiencing. We do have to know, how clear vision is, what the prescription is. Are the eyes healthy? Is their peripheral vision intact? So we have to know this information. But then the neuro-optometrist takes it one step further and dives a bit deeper into things such as, tracking of the eyes, how the eyes are working together. Are they fighting each other? Is there stress in the system? Are the eyes integrating well with the balance systems in the body? How are the eyes integrating with the neck? How's visual memory? All these sort of visual perceptual things. So there's definitely this dive deeper into the brain with respect to the eyes in a neuro-optometric exam.
And would a neuro-optometrist also engage in standard optometric examinations, or you typically, divide your practice at that point and you go, okay, I'm going the neuro-optometric route versus, standard optometry?
Well, for me, I see regular patients as well. Like that's part of my practice. So I don't only do neuro-optometric assessments, but in order to do a neuro-optometric assessment, the patient would have to have a general eye exam either after their injury, if it's been within a year, or an eye exam in general, if it's been over a year. That's my criteria. So they have to come in with that baseline information, or I do it in my office first, a general exam, then they come back another day, because it would be too much on one day to do both, to do the neuro-optometric assessment. But I need that baseline information in order to proceed further. Because I have to know, is there a cataract in the way? Is there, an issue affecting their vision? I need to know about this before going into the functional part of things.
Do standard optometrists screen for neuro-optometric deficiencies and refer for that? Because we have a lot of patients that will say, well, I've been to an optometrist and my eyes are fine. And, obviously I'm saying, well, it's different. Like, I know that it's different. Would most standard optometrists pick these things up just in general examination and say, look, I think you need something more advanced, or would they typically, miss these types of things?
So, history is key, of course, right? And to ask the right questions. As someone, is complaining of certain visual symptoms, and, if there's a concussion history, it's important to note that. But there are optometrists who are well-versed in sort of how to screen for this. Like they've attended courses by neuro-optometrists saying, hey, this is what, some key tests that you can do to look for this. Other optometrists, they might not have that education, but they might know who to refer to. So that's what I did when I first started the specialty. I was doing my general optometry exam, and the patient presented with all these different symptoms, and the exam was perfect. The general exam was perfect. And I'm like, how can I not I don't know how to help her. And so I referred her to a neuro-optometrist who I knew in the area. At least I knew to do that to help her out. But I knew that the general exam just wasn't enough for me to really solve her problems or figure it out. And it wasn't explained by the findings in the general exam. So yeah, so I mean, it's really, up to the optometrist to be educated on sort of what questions to ask, what to look for, that kind of thing.
Kind of par for the course for all healthcare professionals, I guess, right?
Correct.
Some know, about concussion and many don't. So I think it kind of goes hand in hand. Now, in terms of neuro-optometry, I know concussion is a big focus, but a lot of it is, on the developmental side with, kind of like idiopathic things. So how would a behavioral optometrist be the same as somebody that would do concussion work? Are those two things synonymous? Is the process the same, or is it different because of one being something, let's say, from birth versus something related to an injury?
Exactly. Even when you approach, therapy, you have to approach it as vision therapy for the developmental side. So you're sort of addressing something that didn't quite develop as it should have, versus rehabilitation, which perhaps it developed perfectly, and then because of injury, it's now dysfunctional. So you have to sort of get it back to where the state was before. So there's a different approach or different mindset when it comes to the developmental side versus the injury rehabilitation side. And, it's interesting within sort of the vision therapy community, there are different specialties, like I will send to colleagues of mine, if there's a 2-year-old with a turned eye, they're better sort of colleagues who can, facilitate that therapy, or they'll refer to me for brain injury. So they're definitely different mindsets. And neurooptometry, it's not just concussion. I mean, I also see, Lyme disease patients or post-viral. I've seen post-COVID, a few post-COVID actually right now.
Really?
Yeah, like those long haulers,
Yeah, and
which is interesting.
they have visual dysfunctions.
Yeah, and
Wow.
very kind of comparable to almost the Lyme disease profile, like just this
Mm.
post sort of infectious profile, which is interesting. So it's not the same as a concussion case, of course, but I see these sort of similarities. Fatigue, photophobia. There's just different patterns that I see with these
Mm.
different populations.
Mm. I think there's overlap.
Yes.
Just looking at the symptoms of post-COVID and then post-concussion, I think there's a lot of overlap, particularly from like an inflammatory perspective, a neuro perspective. I know myself and Dr. Herkel have talked about this as well. So that's interesting that you're seeing the visual side too. That's really really interesting. Um,
Right.
from a obviously being a concussion show, let's go down the concussion path. What would you say are the most common visual dysfunctions you see in a post concussion patient? Um, and then I'll kind of follow that up once we go down this rabbit hole, because I want to know, beyond that, what might a patient, what may tip a patient off that may be listening to this thinking like, these are the symptoms that I have. Maybe this is what's going on. But also then what a clinician may, look for or tease out from their history that may tip them off to say that they need some vision therapy. So let's start first with the most common
Right. Because
issues
this
you
is
see.
one of those long answers to a short
Yeah,
question.
yeah, right. Yeah, well, the
Um,
question wasn't that short. I tend to ramble, but
it's okay.
go ahead.
No, fair. So sorry, starting with symptoms you mentioned,
No,
or
I
sorry,
the most common
finding.
the most common visual dysfunctions you see, is it?
Okay, because yeah, we can separate this into sort of symptoms the patient might present with and findings
Mhm,
in the actual assessment, right?
mhm,
So going with findings, I often see things like sensory integration dysfunction. So the eyes are just not communicating well with your vestibular system, your sort of inner ear balance system, not communicating well with where you are in space. Your proprioception systems or the neck might not be communicating with the eyes. eye movement disorders. So it's not like overt, like I can't move the eyes, but just sort of the quality of eye movements, could be dysfunctional. Binocular stress. So the eyes are fighting each other. So you can have perfectly aligned eyes, but they're just fighting each other. And that can cause a sort of visual stress that can affect many tasks. Visual motion sensitivity, that's a huge one. Just sensitive to things like, that goes to symptoms now. But with testing, you can actually sort of see this as well, trigger this with certain tests. And, you can have visual perceptual things like just not being able to remember what you just saw, or sort of mentally manipulate visual patterns. Oh gosh, I can go on. But those are very common. And convergence issues, that's a huge one, where the eyes just can't quite follow a target inward well. And that's a huge topic on its own. And a final thing that is really important is the sort of functional peripheral tunneling. So even if someone has perfectly fine, intact peripheral vision, their ocular health is fine, but they're sort of functionally not processing things in their peripheral vision well. So whether it's they can't process movement in their periphery, or they're startled with things coming from the side, their peripheral vision is just not quite on. And that can be very disorienting for a person. So it's kind of bleeding into sort of the symptom part of things, but these are, certain, findings that I see. So if I see someone reading and they're moving their head as they're reading, that's a sign of tunneling because they're not using their eyes fluidly. They have to use their head. There's no peripheral vision to be able to see the line fully. Just things like that.
And why does that, why does that happen? Is it I'm not sure if we know the answer, but is it because they're very focused on their, focal vision? Like they're very focused on, this, like, and is that some sort of adaptive strategy to something, or, how do you see that?
Yeah, I mean, we can go very scientific with this as well, but patients tend to be very over focalized. So they're almost looking at a busy scene in sort of piecemeal, snapshots in time and not getting this visual grounding. So it's very disorienting. It's kind of like when you're driving through a snowstorm and you put the brights on, you focus on individual snowflakes coming at you. And it's sort of that weird disorienting feeling versus if you sort of let your vision open up and then you can sort of ground yourself. It's a common analogy that I give. So people tend to be very over focalized and not really utilize their peripheral vision. So part of therapy, the first part of therapy is to really try to open them up and try to get vision a little less tight and more open with peripheral vision.
So with all those kind of conditions or presentations that you see, is it common that you're going to have more than one of those in any given patient, or is it usually like, they're either going to have tunneling or they're going to have, something else, or some saccadic dysfunction or something else, or is it no, they're going to have a bunch of stuff and we're going to start, working on it kind of simultaneously?
I mean, the brain is so complex, right? So typically I won't see one finding in isolation, like we're going to target that and that only, and that's the way to, but one thing can trickle into the other. So, if someone is tunneling in their vision, their eye movements won't be quite as fluid, because you need that peripheral vision to sort of track something. Otherwise it's going to be choppy, or you need the peripheral vision to know, like making a saccade or a fixation change from point A to point B, you need to know with your peripheral vision where to go. Your brain has to plan that. So if you're tunneling, then it'll be sort of choppy in that movement as well. So you can sort of piece some things together versus like an isolated finding. But there are different kinds of things we can see, but it all sort of, it comes together as a clinical picture, very typically.
Right. And is there things that you would tackle, first, second, third, or do you kind of go after, I know with us, like when we're looking at something, like let's say from a vestibular standpoint, like you start with like, okay, like we're going to start at this level because this is kind of, more basic than this. And then you kind of build on that. And I'm assuming you kind of follow the same.
100%. So for example, if your peripheral vision, if your spatial vision is just not there, you're not going to be able to do anything with your eyes. I mean, your eyes will just not know what to do. You have to be grounded in space. Sometimes this requires also neck therapy to sort of help with that. Otherwise, I can do all the vision therapy in the world, but if the neck is giving confusing information about where the head is in space, then I won't be as successful. So, there has to be this multidisciplinary effort. But as far as my approach with vision rehab, I mean, you got to have that spatial vision first. You got to be able to fixate steadily on a point, because then you can't move your eyes if you can't even fixate.
Hmm.
You have to keep your gaze stable, and then you can start to work with eye movements, and then you can start to work with the eyes working together, and then sort of higher perceptual memory, visual memory, more the visual cognitive stuff. But there's this hierarchy for sure in how this should be approached. I agree.
Hmm. And it's interesting that you brought up, kind of the other facets of this, because, I think that you and I look at this in much the same way, that, there's three systems kind of working together, vision, vestibular, and the neck, and they'll kind of block each other. Do you advocate for, working on these three systems simultaneously, or do you think there's some sort of hierarchy? Like, if you're like, oh, I'm going to do vision therapy, but, I think they should have their neck cleared out first, or would you say we can keep doing vision therapy, but simultaneously I want you working um, with somebody through neck and vestibular, stuff? Or how do you kind of plan that out in your mind?
Well, it's an excellent question. And it's a question that, I might not have all the answers to, but I believe that a simultaneous approach is a good approach. However, if there's for example, a primary vestibular issue, like a BPBV, like something where the crystals are out of whack, and that has to be sort of fixed first, I think, things like that before I proceed. But yeah, I mean, people have these chronic neck issues. So for me to wait until the neck is completely healed, I mean, why not intervene while this is happening? And actually, sometimes intervening with the vision part of things can actually make the neck therapy easier as well, right? So there's a lot of back and forth. And that's why the communication between providers, multidisciplinary providers, is essential. And I often sort of communicate back with my physios and the chiros that I deal with. And we're sort of tag teaming with the patient, and I think that's really crucial
Hmm.
for the recovery.
I mean, I agree with you 100% on this, that it should be done simultaneously, because I feel that a lot of people do this in piecemeal, and I'm not sure why that is. Maybe it's the provider not, educating enough on this, but I find a lot of people say, well, I'm going to try vision therapy for a bit first before I try this. And it's like, okay, well, why don't you work both together? Because you're gonna hit a point in your vision therapy that if you do have these dysfunctions, let's say in your neck or in your vestibular, function, you're gonna hit a point in your vision therapy where you're gonna get blocked by these other dysfunctions, where it's gonna kind of, I think, plateau for you, where you're just not getting that benefit because you're not fixing the other pieces. But working together, it's like, okay, you're gaining stuff on your vision, but then now you're gaining stuff with your neck and vestibular that's now unlocking, the potential for your eyes to do better. Um, I actually read a study that vestibular therapy, it was this like critical review of vestibular rehab for concussion. And they found that patients with dizziness, post concussion dizziness, automatically, and if you read any of the like medical, consensus statements, and there's like clinical practice guidelines for sports med physicians, and all these different things, they'll try to categorize concussion into these kind of subdomains based on symptom presentation. And so they'll say, well, if you're dizzy, you
Therefore,
have a vestibular concussion subtype. So vestibular rehab is where you go. And then simultaneously, you have vestibular rehab specialists thinking that, well, because I'm vestibular, I know concussion. Like, we would go to these conferences down in the States, and we'd be talking to people about concussion, and they'd come up and we'd say, oh, do you see any concussions? Oh, I'm a vestibular therapist. It's pretty much all I do. And you're like, oh, okay. So, but how about the rest of the picture that's included in that? So there's this thought process, I think, in the healthcare world, that if if you have dizziness, then it must be vestibular, but it's not necessarily in that way. And actually, this critical review found that the effectiveness of vestibular therapy for people with post concussion dizziness was only between 25 and 50%, which means that between half and three quarters of patients are not going to see improvement, even though they're dizzy and even though they're seeing vestibular rehab. And I think vision could be a missing component of this. I think neck is likely a missing component of this as well. Um,
right?
so
Yeah,
working together, I think, is the only way
agree.
to really do this. Because if you try to do it in silos, I think that you're going to go down the path of vestibular. You're going to get blocked because there's something going on with the eyes that hasn't been addressed. You're going to hit a plateau, and the vestibular therapist goes, I can't help you anymore. So then now you're maybe gonna, fumble around, maybe stumble into vision therapy if somebody kind of tips you off that way. You're gonna go there and you're gonna do, that for a bit, but then you're gonna hit another block because maybe something in the vestibular now is now unlocked, right? The way that I kind of describe this is like, picture yourself sitting in a room and it's this circular room with all these doors, and each one you can open the door and lead down a tunnel, and you might get to the end of that tunnel and there may be a lock on the door and you can't open it because you didn't get the key, which was the tunnel down the vestibular side that would have unlocked
Wow,
the
what a
door.
good analogy.
Yeah, like it's some doors will have locks and some doors will have keys and some hallways will have keys, and you need to have the key to unlock the door, but you have to kind of do them in the right, way and together. So,
And there are many studies, like the limitation of studies, I think, is that you're right. Like they sort of go into these silos, and we need more studies that are large scale but multidisciplinary.
mhm,
That's the thing, right?
mhm.
And that because everything is all connected. How can rehab not be that way as well? That's what I think, right? So,
Yeah, and I think when people are working in the research world, I think that there's this concern that, and I think it's a valid concern, that if you put too many things into the study, the question is going to be, well, which thing helped? And so, how do you really learn anything from that? Because all of a sudden, it's like you're doing everything. So
mhm.
maybe you only needed to do one. And so, a lot of people start with, okay, if we do this one thing, what's the benefit? And then they may find that it has no benefit, but in reality, it may have tremendous benefit. But it needs the key to unlock it to be able for it to have that maximum benefit. So, and I also think that there's you know, um, the silos that people work in. So if you're a vestibular therapist, you're trying to prove that vestibular rehab is effective. So you're going to just focus on that and not want to bring other people in. And I think the same thing goes probably for neurooptometry, is they focus just on the optometric side, and they don't consider that, maybe if we brought in, some neck work here, it might, unlock some of this stuff and help it out. So I'm 100%
And
with
not
you on
only
that.
that, yeah, not only that, like, I mean, inflammatory, factors, thyroid, like gut brain issues. I mean, this is where Paul Herkel would
Hmm.
come in, Dr. Paul Herkel.
Yeah.
You have to deal with that as well. I mean, just, calming down the nervous system, making sure everything is in balance internally. That's another factor that's usually not necessarily looked at, I find, as
Mhm.
a first line of defense, but I think it's super important.
Yeah.
So that's a part of it too. And there's a concern I've been accused before of like promoting practitioner burnout by saying, okay, this one for this, but at the same time, you really need a team. I think
Mhm.
I find the best success stories are those who really have a team versus one person attending to their care.
Yeah.
Um,
As long as that team is on the same page.
yes. And communicating, because
Yeah.
this is where we have to work more on, like what we have to work more on,
Yeah.
I find.
What
And
I've
I really promote that.
what I've found with um interprofessional collaboration on this, it's like, okay, I need to find an OT, but I need to find one that has the same thought process as us, because if I send them to somebody else, they're going to give them a different story to the patient, which is going to be confusing. Right? You may send them to a healthcare professional. It's like concussion is permanent, your brain is damaged, and that's it. And then they come to me, and I'm like, well, no, there's some dysfunctions that can be rehabbed, and we can fix this. And now you're creating confusion there. So it's like you need to kind of find, you need to make sure that people are on the same page and speaking the same language, because then it's like, oh, they're all telling me the same thing. Okay, then I'm more likely to comply. I'm more likely to go along with it and do the work. And I think that's important.
Unfortunately, and this is really the reality, and I see this all the time, patients are navigating the system on their own, not knowing where to go.
Right.
And they don't know who to find, they don't know where to start.
Mhm.
No one's really quarterbacking the process.
Mhm.
It's tough for a lot of patients to sort of know what to do. And so, starting by with one person, but at least that one person can say, okay, you need to go here to do this. You need to go here to do this. This is what I
Mhm.
often do, actually, if patients
Mhm.
are not sure what to do. I'm like, okay,
Mhm.
I know a practitioner in your area
Yeah.
who can work on this. I need an assessment of this,
Yeah.
or, and then we'll
Yeah.
go. So sometimes I'm the quarterback.
Yeah.
Um, in
Well,
this.
what we're trying to do now with CCMI is kind of create the ability for that to kind of happen in a more natural way by connecting the healthcare professionals. So right now we're actually building a program for OTs, We're building what we're calling physician and specialist programs so that we can like have neuro-optometrists go through kind of base level, concussion training to know what everyone else does. And now you can have a layer of neuro-optometrists in there, and they can refer to each other, and they know who's in the network. They know who's speaking the same language, and everyone can kind of work together. And as a patient, you can come to Complete Concussions, find a clinic, but also find any specialty you're looking for. So if you're looking for vision therapy that knows concussion, you can find that list there, right? And so that's kind of what we're trying to build, so that it makes it easier for the patient to find what they actually need, or at least find information that may, give them information that can say you may need this. But
Exactly.
yeah, so let's get back into vision. We've
Yes, sorry.
taken a little sidebar there, but I think it's good. I think this is a
Yeah,
great,
I agree.
it just kind of goes this way. But so let's say I'm a patient. There's another condition actually I want to ask you about
Okay.
after, but
I
let's talk first
okay.
about what are some common symptoms that may tip off a patient. I mean, we obviously mentioned them when we're talking about the conditions, but what are some other ones that I'm a patient and I've been, let's say I'm dizzy, I have some headaches. What may tip me off that a neuro-optometrist may be able to, help unlock something for me?
Well, so for dizziness and headaches specifically, I mean that's really something that a practitioner has to kind of dive a little deeper into, because it might not be primarily visual in nature necessarily, right? So, a practitioner might say for dizziness, is the room spinning, or do you feel like you're spinning? Is it more lightheaded is it more when you get up? Like when you lie on one side, is it better than the other side? I mean, just different probes to see perhaps more of a primary source of dizziness. Now, it can also be visual as far as dizziness, and this is where we would come in. So, oftentimes, I would discover something like a small vertical misalignment of the eyes, whether it's because of vestibular dysfunction, or whether it's because the neck is just off kilter, or just their eyes have just sort of had that, it just got that tone after an injury. And that is a source of disequilibrium, dizziness. So you have to be a detective really to figure out, okay, what's sort of causing that. But a patient being dizzy, I mean, they'd have to go to a practitioner to sort of suss that out. Headaches, I mean, that's a whole other topic, obviously, right? So, but I tell patients, listen, if you wake up with a headache, it's likely not visual.
Hmm.
So that's like a big clue for me. Or there's certain locations in the head where I might be like, doesn't really sound visual. Like visual can be, frontal. It can be at the back of the head as well. But a headache on one side, like over here, not so much necessarily visual, right? So, so there are clues that we might sort of get from a headache probe that's visual. But anyway, but other symptoms, I mean, something as simply as when I'm reading, I'm losing my place. I'm rereading. Words are moving or shaky. Um, the page seems overwhelming. Like it's so busy to me. Um, things are blurry. Things are doubled. I get dizzy when I'm reading. I get nauseous when I'm reading, or even nausea in the car. Things bother me. I can't track things, like if I'm watching a hockey game, I can't track players, or I'm having difficulty with that. When I turn my head, my eyes feel choppy. They don't feel quite smooth. Things startle me from the side. Or when, my kids run around in front of me, that really bothers me. Or I'm a teacher in class, and that really, really bothers me with all this motion in front of me. Lights bother me. I can't be on the computer screen for more than, 10 minutes without feeling a massive headache or dizziness. You know what I mean? So there are different kinds of clues. Scrolling bothers me. I can't scroll on Instagram because I'm completely nauseous from doing that. Never mind someone else scrolling in front of me, even me scrolling, doing the scrolling. So I know I'm going on and on. I'm probably talking quickly, but I mean, I see this all the time. Not every symptom is visual in nature, but I have to suss out if there's a visual component causing these symptoms as a neuro-optometrist.
Hmm.
So just some examples there.
Yeah, I think it's interesting because there's no one point that says this is going to be vision. And I think that's, kind of the point that we're getting across here, is that you can have these symptoms, but those same symptoms could be neck related. They could be vestibular related. They could be inflammatory. They could be autonomic. They could be a whole host of things. So the only way to figure it out is to start crossing things off the list. And if you're thinking like, oh, I'm in vision therapy and I'm not getting better, then you have to realize that it's not that vision therapy doesn't work. It's that you may be missing the vestibular and neck and inflammatory and other components that go along with it. And so adding that, not
Exactly.
taking one away and adding those in place, but adding that to it
Exactly.
may unlock that further for you, because all of these things work together. And if you have the right people working on the right pieces and they're communicating together, I mean, it's quite effective.
That's your best bet.
That's your
Exactly.
best bet. That's your absolute best bet. What is visual snow?
I knew this was the condition you were going to ask me about.
It
And it's a great question. And it's
it sounds
extremely important to ask them.
freaky when people tell me about it. It's like
Okay.
yeah, go.
I
Go.
know. I'm going to just go. Okay.
Yeah.
So visual snow is a very, it's an odd condition, and it can happen with a concussion or without. It doesn't have to necessarily be due to a concussion, but it can happen. I've seen it after a concussion, where people have these really strange visual sensations, and that can range from things looking very staticky, almost like a kind of bad TV sort of screen. Literally, snow might appear in their vision. Both eyes, not just one eye. It's
Mm.
both eyes, and it persists with eyes closed, by the way. So it's not
Mm.
just like eyes closed, it's gone. It's typically with eyes closed as well. It can be precipitated more with stress, or when the system is kind of jacked up, or in the sympathetic fight or flight mode, then you can have more snow versus like a flurry.
Mm.
You can have things like after images. So you look at something and you look away, and that imprint is still there for a moment or so. Also, colored lights can come, or trailing of lights. That's another sort of really strange phenomenon. It's thought to be due to sensitivity in the cortex, like just sort of this hyper excitability in the brain
Mm.
that causes this. So it's a very interesting phenomenon. And it can sort of wax and wane, I find, or it can be constant, but it's not migraine. It's very different than a migraine aura.
Mm.
So that's a distinction. So people will say, "Oh, it's probably just a migraine," but no,
Mhm.
it's a very different classification than a migraine.
Mm. So now that you're describing this, because I do get migraines with aura, and sometimes I'll have these imprints that I will think, "Oh, I'm getting a migraine," but they subside. Is
About
that
20 minutes, half hour, 10
yeah,
minutes,
no, well, not even that long, like 5.
5 minutes.
Yeah.
Yeah,
Does that
yeah.
sound like a
This is
visual
not.
snow type of thing?
No, it's definitely more kind of more constant.
Mm.
Um, but I find that first of all, identifying it, like labeling it and telling patient, okay, this does not sound crazy. This is
Mhm.
what it is.
Right.
It automatically makes them feel, okay, I know what this is. I'm not just seeing things and wondering what this is. So just reassuring. We still don't know everything about visual snow. Um, as far as sort of management of visual snow, so there's some studies in the literature showing that certain color tints can
Mm.
actually mitigate some of that excitability or some of that perceptual those sensations. A colleague of mine in the U.S. actually, I think the study is going to be published early next year,
Mm.
showing that vision therapy over a course of 3 months can actually either eliminate or significantly reduce the snow just by virtue of strengthening the visual system and doing vision therapy.
And
So I
it probably calms the nervous system too.
exactly,
Yeah.
pardon me,
Yeah.
exactly.
Yeah.
So you know, that's really, a big factor, so are we calming the nervous system? Are we sort of strengthening these connections? I don't know. I don't know
Mhm.
why,
Yeah.
where the mechanism is, but it's definitely a thing. Visual snow, pardon me.
No worries.
All this talking.
I'll talk. Um, while you sip. Um, so just in hearing that description of it, it almost sounds like it, especially when it's like stress, and if you think about autonomic function and dysautonomia, because that's tightly regulated with blood flow. And this to me almost sounds like, some sort of blood flow issue. Like, you stand up too quickly, you get kind of lightheaded, and you can see that speckling in the vision. Is that the same type of thing?
No.
No?
That sounds interesting to me. I don't know.
Yeah.
To be
Yeah.
honest, yeah, I'm
Yeah.
not sure. But there's uh, a website, I think it's the visualsnowinitiative.org.
Mm.
And there's a whole bunch of information on it for patients like a good patient resource
Visual
that
Snow
people.
Initiative. I'm just writing this down so I can put it in the
Okay.
show notes for people after. Visualsnowinitiative.org.
Initiative.org.
Okay, cool. Cool. I get asked about that one actually more than you'd think, and I'm always puzzled. I'm like, oh, I don't know. So this is a new one for me in the past couple of years, but now I feel like I'm hearing it more and more.
Yes.
And actually, even just having your description in this little brief conversation about it, we can put that as like a sub clip on YouTube, and people might be able to find, just a brief little description of it, which is nice. Okay. Now, if I'm a clinician and I'm working with this, are there certain objective findings that I may pick up on an examination? Let's say I'm doing a cranial nerve examination. I'm looking at ocular motor tracking. I'm doing H patterns and things like that. I'm looking, doing just kind of a rudimentary visual acuity, or convergence even. We look at convergence with the VOMs kind of thing. And we're not obviously doing to the level of like neuro-optometric evaluations, but what is something that a clinician doing some of this stuff should just keep their eye out for and say, I think this person needs some more advanced vision work here?
I mean, obviously, if there's restriction of movement, one eye relative to the other, like just any sort of gross range of motion issues, if someone's not sure, definitely send them out.
Mm.
Are the movements choppy versus smooth? And if they're not sure, send them out, kind of thing. When you're looking at saccades, are they grossly slow? Are they really like not accurate, like sort of a lot of jumps to get to the next point? Just, things like that would be obviously abnormal. Something that I look at with eye movements, which is interesting, is body sway. So if the patient can stand, I'll have them stand and I'll check eye movements. And even if the eye movements look perfect, but they're starting to sway back and forth because of the eye movements, then I'm like, there's something up with their proprioception. Like they're not sure where they are in space, because when the eyes move, technically the brain's like, okay, we're going this way, but the body has to be like, no, we're centered. But if there's an issue with that sense, with that sort of sense, then that's a bit of a flag for not necessarily eye movement issues, but proprioception. So looking at the eyes to determine, okay, what's going on in the body, for example. And if, just a quick kind of thing that I'll do, and, sometimes it's really astounding. If I'm testing saccades and having a patient look back and forth between 2 points and they're like, oh God, that makes me feel disgusting. That makes me feel really sick. And I'll put a white page sort of as the background, like a blank page, and have them do it again. And if they're like, oh, that's so much better, then the problem is not necessarily the eye movement itself, but it could be the I call it the whoosh factor, sort of that that visual motion sensation in between points. And that's something called lack of saccadic suppression. Normally the brain should be able to suppress that. But after concussion, the brain's like, whoa, what was that movement in between points? And that could be very symptomatic. So imagine looking around a busy environment and having like whoosh, 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 whoosh happening. That can be extremely troubling, symptomatic for somebody. So just like a little thing that I try just to see what happens. But yeah, visual motion could be the issue causing the symptoms with eye movement testing versus the eye movements themselves. That's sort of something to think about.
Mm-hmm. We do that. I use a blank page when I'm doing like BPV testing, because sometimes people can fixate on a point in the room and suppress the nystagmus. So I'll use a blank sheet,
right,
just to not allow them any point of fixation. So it's interesting. It's almost the reverse, I think, of kind of what you're trying to do. But anyway, yeah,
it's a different application, but it's certainly yay blank page test.
Yeah.
No,
yeah. Fancy. We're getting fancy over here,
right?
Can you see like like even just doing like cover uncover tests with that, like because you do that sometimes just for looking at just those little subtle kind of eye movements, and what would you pick up like like that vertical misalignment you were talking about? Would you be able to do that kind of with the naked eye, or do you need more advanced?
So as experienced as I am as a vision professional, sometimes I actually miss very subtle misalignments. So I'll do specialized testing to see if there's any vertical like really subtle vertical. And sometimes I prescribe like the most subtle compensating prism to help with that. Like, and I go back again to do the cover test. I'm like, I still can't see it. But then
Yeah.
on this other test, I'm like, oh yeah, it's there for sure. And then when I put the prism on, they're like, oh, it feels so much better, and I can see clearly, and I don't feel off. And
Right.
so,
So you can't necessarily rely on that. So
no,
if it's not present, it doesn't necessarily rule it out. So it should
correct. And
still be
also, if
evaluated.
the yeah, and if the eyes are aligned and there's no obvious kind of misalignment of the eyes, doesn't mean the stress is not in the system. Doesn't mean the
Mm,
eyes are not fighting each other.
mhm,
Like I'll throw in a test that sort of has one eye seeing one target and the other eye seeing another target, and like you'll see kind of the movements of the two targets. So the eyes are literally doing this,
mm,
even though on a cover test it might not reveal that. So there are just certain things. It's really the subtleties
mhm,
that get at people. Gross abnormalities, I mean, that's a different story. You deal with that. But I mean, it's really detecting that subtlety
mhm,
that's expending this energy in the brain
mm,
over the course of the day.
mhm. And you mentioned even losing your place on the page when you're
Yes.
reading. A lot of times, um, patients attribute that to cognitive issues. Patients will say, "I read something, and then I have to reread it, and then I have to reread it," and they'll think, "Oh, my brain isn't working, my memory isn't working, I'm not able to think straight or focus. I'm losing my focus." But a lot of that could actually be vision related as well.
But it can also be what you're referring to, right?
Mhm,
So the key is, in my mind, is rule out the visual piece first, and if it's still happening, maybe there are attention issues,
mm,
concentration, working memory, other non-visual parts associated with reading. But losing a place on a page, it can certainly be a spatial issue. Like the eyes just might not know how to judge where to go because it can't judge the space between the words, or kind of
mhm,
judging straight line, if the line is straight. Um, so it's important to sort of figure out, is it may not be like an eye movement issue per se, like the eyes can move, but
mhm,
it's the judgment of how
mm,
to move the eyes, of how to track. That
mhm,
might be a big problem. Or are the eyes like fighting each other as they're going along? I mean, this can certainly, cause reading issues. And, you know, when I fix these, or when I sort of address these, and then they're like, yeah, no, I'm still losing my place. They're like, I don't know if it's a visual thing at this point. I think you
right,
have to intervene, say with speech language therapy, or figure out if there's like an attention component, and go from there.
mhm,
So it's not necessarily only vision.
mhm. Yeah, I mean, if you just think about just trying to read, like, one word at a time and not reading it as a sentence, like,
Yes.
normal, healthy reading it as a sentence, you can interpret that a lot better. Sometimes you're distracted, I'll be reading like papers, for example. I'll be reading, medical journals, and I'll be thinking about random things, and I'll
Me
read
too.
I'll read an entire abstract and be like, "Okay, what?" And I'll go back and read it again and be like, "Okay," like you have to just kind of, focus. But
I do that
y-
too.
yeah, if you're trying to go, like if you're, let's say you're, over focalized and your eyes aren't moving well, you're going to go one word at a time, and you're going to get to the end of that sentence and be like, I don't understand what I just read.
For sure. And interesting. When I try, like if I try a prism on a patient, like, I'll have them read some text during the exam, for example. And then I'm like, did it feel choppy? Did it feel smooth? Like, what are you experiencing? It's not just clarity. Yes, I look for clarity, but I mean, what else are you experiencing? And then I'll put maybe what we call a spatial expansion prism,
Mm,
just to kind of expand space visually. And I put that on, and all of a sudden, and I don't feed them what answer to tell. Like I say, okay, what does this feel like, or how are you seeing with this? Tell me what you experienced with
mm,
this lens. And they'll put it on, like, oh, I see more of the line now, or I feel smoother,
mm,
because it's now not as like word, word, word. It's sort of more of a flow, because they can see more and they can flow more through the line. So yeah, so there's definitely this. That's a visual component that can impede reading efficiency, processing.
when it comes to prisms, um,
Yes.
is it something? Because in my my mind, I know the answer better now, but I'm going to ask the question, as if I don't. But in my mind, throwing that on is almost like a band-aid solution. And so how do you use that prism to actually invoke long-term change in the individual? Like, is that a crutch of some kind? And what happens when you remove that prism? Are they just more dysfunctional now because they've been using it, or how does that work?
Such a good question. So prism, I mean, this is a whole topic in itself because prism is used in different ways. So for example, for those who don't know, a prism is a lens that's thicker on one side and thinner on the other side, like a wedge. And as optometrists, we can manipulate visual space and sort of the way the eyes are working together with prisms. So for example, sometimes, the eyes are very misaligned and you'll use some prism just to kind of like make the eyes a bit more aligned. So it just relieves that stress trying to like bring them to level. So the prism can actually help bring eyes more into this alignment, for example. That's compensating. But then you can actually use prism in other ways to expand visual space on one side, have someone sort of feel more balanced as they're walking, and really sort of change the way space is looked at. And that can cause better matches, better sensory matches, oftentimes with vestibular and proprioception to say, hey, now we can click together a bit more. So in those cases, prism can act as a brace. I don't like to use the word, sort of band-aid, but I like to say a brace. It just allows the brain to start to kind of recalibrate, if that makes sense. And, so as their vision is, as vision rehabilitation is going forward and they're doing this other therapies with their other, physio, chiro, or whoever, then, many times these patients will be like, I don't need these glasses anymore. Or the glasses don't work anymore because maybe their sense has shifted and the prism is now shifting them the other way. So I look at it as a brace to kind of get the brain a little less confused. And then as they get stronger with their multidisciplinary rehabilitation, then eventually I tell people like this prism might be for like 6 to 12 months. I've seen people after like 3 weeks come back to me and say, this prism isn't working anymore because they did this neck therapy and now they're not spatially sort of skewed. And I'm like, oh yeah, that's great. That means, your brain is now recalibrated and you don't need that prism to help you recalibrate. So it can get very complex with prism.
Now, in terms of other types of rehab, so somebody may get a prism. What else may they be given in terms of a rehab strategy? Is it always in person? Do you give them things to do at home? Kind of walk me through.
Rehabilitation, and it's not just prism, by the way. It can be colored tints. It can be tape that you put selectively, like binasal tape, on the glasses to sort of help, again, recalibrate vision and space and all that. But rehabilitation is best with kind of a supported program where you do in-office visits, but then home exercises to support as well. I mean, the model of that can be different with different practitioners. Like some people might be very high functioning. They can do, they're pretty independent. They can do most of the things at home. Other people need more support in the office. So you have to play it by ear, especially, when it comes to concussion brain injury. You got to look at the individual and say, okay, what would be most feasible for them? This is how I approach it. But yeah, I don't want to just like throw someone exercise and say, okay, see ya in like 3 months and, keep going. I want to have this sort of constant check-in with them and then modification of exercises. Exercises are best when they're not too hard or not too easy for the brain to learn the best. So to actually prescribe that right formula of exercise requires that support. When I say in clinic, it can also be virtual in some cases nowadays with the pandemic as well.
Yeah, true. I like that little Goldilocks analogy there. Not too hard, not too easy.
Right? Yeah, exactly.
You need to find it just right.
Yeah.
That's a good one. Now, in terms of the evidence around vision therapy, I know that it's kind of controversial, and I think that there's more and more evidence emerging on this topic, but there's still such a pushback against it from certain members of the community, particularly in like the neurology realm and things like that. They really kind of push back on it.
Yeah.
I know you're fighting the fight, but do you see evidence emerging to the point where you think that it'll be included in the next consensus statement? Do you think there's political underlying things that are fighting against it, or kind of what's your sense of what's going on?
It's such a tricky topic for sure. I mean, we don't have large scale farm type thousands of patients, randomly controlled, double blind, blah, blah, blah. Like we don't have that. What I've been trying to do to fight this fight, I guess, as it were, is to piece, kind of smaller scale studies together to create this clinical picture. Say, hey, there's this pattern emerging. Now there are, in recent years, so the past couple of years, there are these vision therapy reviews, like these, meta-analysis reviews, and saying, hey, there's emerging evidence that there's stuff to this, whether it's prism or, therapy, whatever, like just this sort of intervention. But again, this goes back to my, you can't have this as a vacuum, vision therapy as a vacuum with rehabilitation. You need to sort of combine it with other therapies and somehow show okay, if you do all these therapies together with vision therapy, and then this other group of patients don't even have vision therapy, did the group with vision therapy benefit more than the group without vision therapy? I mean, This is sort of how I see that it should be sort of really shown, as far as the benefit. Vision therapy to me also can be okay, put on these prism glasses, go see your physiotherapist, do your exercises with them, and then come back and see me in a month. And I want to see kind of how you're integrating at that point, doing your balance exercises and manual therapy. And then I might proceed with some active therapy. It gets very variable, right? But the point is, if you look, you'll find stuff, and many people just don't have the time necessarily or the wherewithal to really dig in to the literature. This is sort of my it's it's nothing. There's no evidence.
Yeah.
Well,
it's the same thing with diet and nutrition, right? Especially in the medical world, they poo-poo diet, they poo-poo supplements. They think that it doesn't matter at all, right? Because it's, well, I didn't learn this in medical school, therefore it's not a thing. And so, but all this stuff, there's so much coming out on how, diet can impact concussion recovery, and how, there's so much coming out. And I think it's the same thing kind of in the world of vision. And there's people that are set in their ways of just, not paying attention to maybe the literature that's emerging from that space. But yeah, I know there was a recent, I think it was a systematic review and meta-analysis that was looking at convergence rehab, finding that A, people with concussion have convergence insufficiencies, and B, rehab fixes it. And so I think that's a good start, right? To see that level of evidence, coming out specifically around concussion. So, I mean, I think anecdotally, you and I see the benefits in this. What kind of work are you doing with U of T right now? What kind of studies are you doing? Can you talk about it?
I'm not sure. I don't know. Well, there's one study that's going to come out on convergence, comparing baseline versus post-concussion convergence in athletes with orthopedic versus concussive injuries, seeing if a sort of an issue with convergence is really kind of specific to the concussion population.
So without giving us the results on that, should we be doing convergence testing as part of our baselines?
Yes. And 3 times.
3 times.
Meaning, so it's better to have multiple measurements of convergence
on the same day
than just consecutively.
Right. Okay.
Right? Yeah, exactly. Just when I'm measuring convergence in the office, when I do it 3 times, I've noticed that many times, the first time they might be within normal limits, the patient, and then by the 3rd time, they're already out to outside the normal range because there's fatigue in the system. It says something.
Wow.
Or I'll say, the endpoint might be a certain point as I bring, the target closer. And then I'm like, okay, can you recover from that point? And it might take them a long time to recover. So there's a lot of effort in that system because I can't really release that and recover from that. So they're different, pieces of information. But the moral of the story is multiple measurements simultaneously or consecutively.
Do you take the average of that? Do you take the best? Do you take the worst? Or do you just look at all 3 as a picture?
I mean, I look at all three, but I believe the average would be sufficient.
Okay.
This is sort of, yeah.
It kind of makes sense because you would take into account everything just using an average. If somebody was not fatiguing, their average would be, better than if somebody was fatiguing, because their average would start to lag out.
Right. But as an individual, for looking at an individual and looking at the first reading versus the last reading, I mean, that shows me something,
Mm,
versus just looking at the average alone. I like to kind of see,
mm,
how quickly they might fatigue. Um, but also, yeah, no, I mean, I see, patients from U of T. There was another study that was, I guess, because of the pandemic, like there were no athletes, there were no
mm,
subjects, like it was just sort of, but it dealt with peripheral reaction time and whether that's a factor in prevention of
mm,
like risk reduction of
mm.
concussion. Um,
And how'd they measure that?
so
Did they do like a Dynaboard or
yeah, yeah,
Dynavision board?
exactly.
Yeah.
Yeah,
Yeah, yeah.
exactly.
Yeah.
But
That
sad
would
faith was not implemented. So
Yeah, I mean, I think that the University of, I think it's Cincinnati, has done a bunch of stuff on that in football players preseason, showing that those that did vision training using a Dynavision board preseason were less likely to experience high magnitude impacts during the season. And so
yes,
the thought is that, and I've had this thought before, is that concussion risk is, tied to game awareness, and your ability to, see the field better, um, be able to use your peripheral vision better. Um,
and yeah. And
yeah,
did you see that there was a recent study, like really recent, I think like this year, on
yeah.
defensive hockey players doing sort of multiple object tracking,
Hmm.
and their risk of subconcussive injuries was lessened as far as severity,
Hmm.
not frequency, but severity,
Hmm.
just by doing this just throughout the season, just by doing this kind of training, that
Hmm.
spatial awareness.
Hmm.
Um, so the notion of vision training to reduce the risk of concussion is a really fascinating topic for me.
Hmm. I think there's something to it, because even when you look at things, like neck strength was a big thing, right? Oh, we're looking at neck strength. If you have a stronger neck, you're less likely to have, concussion, because you can stabilize the head better. But when you look at just the amount of time it takes to actually contract the muscles in your neck, it's too late, right? Because when you get a head knock, the peak impact velocity happens within the first 6 to 20 milliseconds. Well, biomechanical studies looking at the neck, it takes you at least 90 milliseconds to even initiate the contraction of any muscles in your neck. So unless you have, and then it takes you another 150 milliseconds to get to half of your maximum voluntary contractile strength. So you have to have, 150 milliseconds plus 90 milliseconds. Let's double the 150 to get to full strength. You have to have almost a half second awareness before that hit happens to be able to contract your neck in time to have any mitigating effect on it. So where's the missing variable? Well, being able to see it coming, right? Or, because you can't prevent things where you're hit from behind, or, hit from the side where it's completely outside of your visual field. But I I've always come back to this game awareness principle, because one of the theories on why women get more concussions than men is because, smaller, thinner, weaker necks, right? But I think that when you look at a sport, let's say like hockey, where it's not quite the same sport. Female hockey is non-contact, male hockey is full contact. They have the same number of concussions. So it's potentially a game awareness phenomenon, where if you know that you're going to get hit, you may, learn to keep your head up better, keep a better focus around. You may go into situations like going into the corner and get tight and ready. Whereas if you're playing a non-contact game, you may not have that same awareness, that same visual field landscape. You may not go into corners bracing. And so when impacts do happen, maybe they're more likely to result in concussion injuries. I don't know. But I think that game awareness is a big factor, which
Yeah, and
vision.
there was a study, I think it was 2017, I think so, where youth female soccer players were shown to actually close their eyes as heading a
Yes.
ball,
Yes.
right? So, cutting out that visual information, is that a factor?
Right.
That's the question,
Maybe.
too, right?
Maybe.
it's helpful for, those patients, those people who are listening, who are experiencing this, to understand, like even when I send an intake form prior to a patient, coming to the office, they'll be like, "Oh my God, yeah, like scrolling is an issue. Yes, busy patterns bother me. Yes, there's just certain things I'll probe that they might not even have either thought of until they read that, or they might be like, yeah, I don't know if anyone really understands this." So, those symptoms that I mentioned earlier, I mean, those are really common. There are so many symptoms that can occur, but again, a general eye exam is important and it's crucial. But it's obviously not the whole picture to uncover what's going on in the entire visual system. The brain, over 50% of the brain, well over 50% of the brain is involved in the visual system in one way or another. Like, so without getting too much into anatomy, like for example, the frontal cortex is the initiation of eye movements and sort of that decision making. The parietal cortex, like that spatial judgment. Occipital cortex is sort of processing what you're seeing. Your brainstem allows your eyes to be stable. And your vestibular system as well. Your midbrain allows sensory integration between visual and vestibular and somatosensory inputs. I mean, I'm reaching at different parts of the brain here, and there's just so many, there's a lot of neurological real estate involved in vision.
Mm-hmm.
And so a shakeup in the brain from a concussion, it's not surprising that vision or the visual process is affected in one way or another. And it's impossible to know, for example, if you're hit on, one side of the head, you can't say, well, I predict that vision will be affected by X and Y and Z.
Mm-hmm.
So, they ask me, like, can you predict what's going to happen based on how the head or how the concussion happened? I said, no, you can't. You have to really sort of dive in.
Because everything's sort of bouncing around in there afterwards, right?
Exactly. And so you have to correlate symptoms with the findings, essentially. Not everyone's perfect. I mean, if I get someone who didn't have a concussion, I do a neuro-optometric exam, I'll find glitches. I will. No one's perfect.
Mm-hmm.
But the key is, are these glitches, I call them glitches, and
Mm-hmm.
I think patients like that term,
mm-hmm.
are these glitches in the system correlating with the symptoms they're experiencing? One thing I forgot to mention, actually, as far as findings, is pupil findings. So the pupils are, they're huge. Like when we're talking, okay, I'm going to get into a topic now because this is important.
Yeah.
So light sensitivity, this is what I get commonly asked. Talk about light sensitivity after concussion. It is so complicated. You can get light sensitivity from neck issues. If there's a whiplash effect and your brainstem is affected, your pupils won't know really how to respond, especially to changes in light. So many people, like with sudden changes in light, they get thrown off, not necessarily with the light, turned on for a while. There are particular pathways in the brain that are sensitive to blue light, that are really hyper excitable after a concussion. So the sort of sensitivity to blue light is extremely common. And these pathways also control the pupil response as well. This is autonomically driven. So if there's a dysfunction in the autonomic system, like sympathetic, parasympathetic, fight or flight versus the calming response, then pupil responses can be abnormal. And studies have shown that pupil metrics are definitely different after a concussion. Whether it's like slower constriction, faster dilation, bigger pupils, slower velocity of change. So there's just
there's been a bunch of stuff on that recently.
Yeah, so pupils are huge. I'm actually I'm getting a pupilometer in the office now, just as a side note. So I'm very excited to actually measure that, give the metric versus just me like judging it.
Right.
And then you can compare as healing happens, how the pupils are reacting, because that's a huge window in itself.
And just on blue light, you kind of brought something up there on blue light, right? Because a lot of people are screen sensitive.
Yes.
We have an online program called the Concussion Fix, which is all online. And one concern that people have about joining is like, well, it's on screens. And so, meanwhile, they've been cruising Facebook. That's how they found our ads. So, it kind of is contradictory in that way. But, in terms of that, I know screens have a lot of blue light. Is that the main issue? Is the blue
Great
light?
question. It can be, but not necessarily 100% the picture. So I've had many patients say, I have this blue light filter on my screen. I wear these blue light filter glasses, and the screen is still really, really bothersome to me. One reason that can explain this, I'm not saying it's for everybody, but it's been the case in many patients I've seen, is the flicker effect from the monitor. So, in a non-concussion person, a standard refresh rate of 60 hertz, that's on most computer monitors, will be fine. No problem. You don't sort of detect the on-off of the screen as it's continually happening. But in a post-concussion brain, it might be perceived almost like a strobe light effect. So I'll often recommend that either the laptop have like a gaming quality, like a 120 to 140 hertz, like really high refresh rate, or a flicker-free monitor. There are some desktop monitors out there on the market that are flicker-free. And I've had patients say, "Oh my God, this is just a game changer."
Is
Having
that
a
like
flicker.
the BenQ, the BenQ, BenQ?
Yeah, there's also ViewSonic. There's Asus. The Asus screen as well. So there are a few companies that offer this. Now they are large monitors. So another issue that some patients have is there's a lot of stuff on the screen. It's a big monitor. So I say, okay, why don't you reduce it to sort of a tablet size within that screen? You're still getting that flicker free effect, and you have a blue light filter built into that screen if that helps. So and blue light filter isn't for everybody. I don't like a blue light filter. I don't like the way my eyes sort of look with it. But some patients, they'll say, "Oh my gosh, the blue light filter is just a godsend." And other patients will be like, "Meh, doesn't really solve the issue, but a flicker-free monitor might." Or it could be the way their eyes are focusing, their pupil responses. It's just not really controlled well. So the pixelated font might be just hard for the focusing zoom lens of the eye to resolve. So you might have to address that with special glasses or therapy. So you have to figure out, is it like the eyes, my eyes are doing it, or is it actually the screen that's the problem, or is it both, and try to resolve it that way.
There's some evidence to show things like light sensitivity and noise sensitivity is related potentially to a hyperactivity of the thalamus, which is a sensory integration. Post-concussion gets actually hyperactive. And so that, could have something to do, especially when now things are flickering at you. It's probably even overstimulating it even more. Now in terms of the blue filters, I see a lot of patients get these blue filters on. My concern around blue filters is the sleep issue.
Yes.
Because
sorry, go ahead.
I'm just going to kind of give people a background here, is that
Yes.
blue light is actually important. The blue spectrum of light is actually important throughout the day because it basically shuts off the production of melatonin in our brain that tells us it's daytime. And we have to have that because then when that transitions into nighttime and we lose the sun, now we have all this artificial light around us, but historically when you'd lose the sun, that would tell your brain that we've lost that blue light spectrum, and now we're into, you get that more orangey light as the sun sets, and that starts to release melatonin, and then you initiate sleep onset. So all these patients walking around with blue light filters, not even just for concussion, I see this everywhere. And what is that doing, do you think, from a sleep standpoint?
So actually there was a study released, I think it was last year or this year, I can't remember, where application of blue light in the morning actually helps with brain healing, neurocognitive function, sleep patterns. So blue light is actually important. So, you need to get full spectrum, ideally outside, full spectrum light to sort of regulate your sleep wake patterns. The problem is artificial light. This is where I have a problem with this whole, blue light's not, blue light filtering isn't good. Yeah, you don't want to sort of deprive yourself of that whole spectrum light, but at the same time, if you're in an office all day or working at home on the computer, from a visual comfort standpoint, and also just this blue light exposure, I think a blue light filter for those, it's effective for is great. Or if they're going into a Walmart or or like a big department store, and there's a lot of flickering lighting or fluorescent lighting, LED lighting. It can be extremely comfortable to have a blue light filter. However, you don't want to wear either a tint or a blue light filter all day. You want to definitely have that whole spectrum light whenever you can, especially in the morning to regulate your sleep cycles and to cut out blue light, like artificial, especially right before you go to bed. Like you don't want to be on your devices right before you go to bed.
The study you're talking about was they had blue light versus amber light, and it was placed at like a 45-degree angle. It was artificial. That's why I showed this, but it was placed at like a 45-degree angle within the first like half hour of being awake or something like that. But it actually phase shifted the people with blue light. It phase shifted their sleep to an hour earlier in the night, and they ended up getting an hour more of sleep per night after 30 days of exposure, whereas people in the amber light didn't. So I think that morning blue light exposure is super, super, super important. And then avoiding blue light in the evenings. My wife and I have blue light blocking glasses that we put on at 7, and we wear them for the rest of the evening, so that by the time we go to bed, we're basically artificially creating that as best we can kind of sleep wake cycle. But yeah, trying to get outside first thing in the morning is super, super important, and
or they might
unobstructed.
Exactly. Or they might have blue light. I might prescribe blue light filtering glasses for like the computer for their their course of the day, or for for school or whatever, and then but not full time necessarily, right? So and again, and even if I prescribe a color tint, like I don't want someone wearing dark sunglasses all day every day. First of all, that's a no. For those who are listening, no. You have to expose yourself to light, but not to the point where it's too painful. But you have to really start to kind of integrate light into the eyes for sure. The more natural.
Well, I think that's a good point to leave off. Shirley, thank you very much. I think this was a great conversation. We'll probably have to do another one. There's probably going to be a ton of questions that roll in on this, which means we'll have another one that comes up. But Dr. Shirley Blanc, everybody, you can find her at www.concussionvisionclinic.ca. That's where her information is. Not big on the social media, Shirley, eh? Not big on
I know. I'm a bit old school. I know.
That's okay. But
people kind of find me, but
yeah. So you can definitely find her there, concussionvisionclinic.ca. I'll put it into the show notes for the groups. And if you want to get in touch with her for clinical assessment, you can find that information there. If somebody can't get to you and maybe they're in a different country, how can they find, let's say, a vision therapist that might be able to help them?
So there are different associations where you'd have to find an optometrist near you. So NORA, the Neuro-Optometric Rehabilitation Association. There's the Canadian Optometrists and Vision Development, so COVD. There's a COVD Canada chapter, and Vision Therapy Canada. Well, within Canada, that's the website you can look at for vision therapy optometrists as well. So they're different. All over the world. There are different associations all over the world. But
what's the Australian one called? Do you remember? I've had conversations. I'll also put it in the show notes. I'll put it in the show notes.
Yes. No. I'm very embarrassed that I.
It's like the Australasian. I think it's OA. Yeah, I'll put it in the show notes.
I'm embarrassed.
Yeah, that's okay.
There's one in the UK. There's a bunch definitely all over the world for sure. Okay. It's through NORA or through one of the websites, you can contact an optometrist and say, hey, do you know anyone in this country, or how do I get to someone in this country? Right. Someone can always direct you.
Right. Cool. Thank you, Shirley.
Thanks, Kim.
Cheers.
Thanks everyone for listening.